Okay, we'll get started. Okay, maximize that. Okay, so we're doing two lectures today, disorders of consciousness and then movement disorders. I'm trying to get the desktop PC to work to show you the videos, because there's a bunch of them, uh, but I'm not getting it to work, so you may have to just follow along on your own screens. Um, so we're talking about people who have episodic or continued loss of consciousness. We're going to go over syncope, review a little bit of the cardio stuff because it does relate to the neuro, because when someone comes in with syncope, again, you have to figure out, is this a cardiac or a neuro cause? Seizures, narcolepsy, coma, and then brain death. Definitions to start. Syncope is just a loss of consciousness due to cerebral hypoperfusion. There's not enough blood in the brain, so we pass out, so gravity doesn't exist really, and blood can flow to the brain. An aura. Brief symptoms that may precede the onset of a seizure. So an aura. The seizure itself is an episode of altered consciousness, and then these over-synchronized discharges, and that causes the seizure activity. Epilepsy is not a one-time seizure. You have to have recurrent events of seizure activity, at least more than 24 hours apart, to be considered to be epilepsy. So epilepsy by itself is not one seizure, you gotta have multiple. So loss of consciousness, again, both hemispheres are affected. Whenever you have complete loss of consciousness, both sides have to be out. That's why when blood pressure goes down, there's not enough perfusion and both sides of the head or the brain are affected, and then you pass out. With a seizure, you have to have generalization of all this episodic discharge from one side to the other side, or both sides off the start, then you'll pass out from that. So syncope versus seizure. The etiology determines how you treat the patient. If it's a cardiac cause, you're going to do more of a cardiac workup. If it's a neuro cause, you do more of the neuro stuff with the EEGs and stuff like that. So syncope, common complaint when they come to the hospital. 3% of all visits to the ER are just due to dizziness, lightheadedness, syncope, and so forth. Transient loss of consciousness, postural tone, so they can't keep themselves upright. The postural tone goes away and they fall down. Prompt recovery with a normal syncopal event. They wake up and they're okay. And these are usually the cardiac causes. So vasodepressor syncope is the main one. This is just your common faint, vasovagal, all the same words. They're all talking about the same exact thing. Initiated, by stress, pain. What was the triggering event that caused them to pass out? Mainly occurring in young females. They get nausea, diaphoresis, tachycardia, pallor. They can have seizure-like motor movements with a syncopal event, but that does not mean that they're seizing. But they may look like they are having a seizure, and they may be twitching a little bit. That's just due to the syncopal event, not due to a seizure itself. Enhanced vagal tone, hypotension due to peripheral vasodilation. So remember, when I'm upright right now, so the majority of my blood, and you guys are sitting down, is in the veins in the legs. And you see the people at attention during these parade things, when they're supposed to be wiggling their toes, because that keeps the muscle pump in your calves working to push the blood back up to keep it circulating so you're okay on the arterial side. Well, when they don't do that, they stand at attention for so long, eventually all the blood pools in the venous system, and then nothing in the arterial, and they pass out. So you'll see people just fall over just because of orthostatic stuff, or vasodepressor syncope. Once they lie flat, it goes okay, and they prompt recovery, nothing needed, you don't need to treat them or anything, they just wake up and they're okay. There's a really good cause for that, you know what happened to those people. Orthostatic hypotension, here's an postural hypotension. This should all be a repeat, I'm not going to go into much detail about that, but remember that's a 20 milligram drop from going from sitting to standing. It drops too much. Common in elderly, hypovolemia, so dehydration, your vasodilators, and obviously diabetes as well, with that autonomic dysfunction that they have. The other key thing with cardiogenic syncope, no prodrome. They don't feel like they're going to pass out. It kind of just happens usually. Sometimes with the orthostatic stuff, the blood pressure, they may feel like everything's going black and going away from them. But usually, they just, especially with like a VFib, VTAC, they'll just fall. Nothing else going on. Usually with cardiogenic, it's exertional or post-exertional. So while they're doing the activity or immediately following the activity is when they can have issues. Mechanical problems, these are things to do with the pump of the heart itself. So aortic stenosis, pulmonary stenosis, HOCM, all those things are mechanical problems that can cause syncope. And then your arrhythmic causes, so electrical system of the heart. And obviously there's your sick sinus syndrome, those long pauses, nothing's beating, nothing going to the brain, pass out, conduction, and obviously your tachys. Testing as for cardiogenic syncope, it can be done mainly as an outpatient. They don't really need to be admitted for this stuff. And just monitor your rhythms. You can do some blood pressure and heart rate responses. EP studies are more if you're getting refractory syncope, not refractory, you're getting recurrent syncope, you're having issues with your heart rhythms, then they can do more things with that. Most of it is just patient counseling. You can give beta blockers for autonomic dysfunction. It helps with vasovagal stuff. Again, it sounds counterintuitive that you're giving people with syncope a beta blocker, but in these patients, it does well by blocking the sympathetic input. Pacemaker if they need it. Watch out for volumes and vasoconstrictors to keep that blood pressure up for those patients. SSRIs and so forth. So your differentials for syncope, there's a whole bunch of them. So anyone coming in with a syncopal event, I know this is neuro, so your brain's going to go to neuro, but on the PANCE, it could be anything. It doesn't matter. As far as they come with syncope, then your brain's, okay, is this cardio or is it neuro? Okay, moving on to seizures. Okay, he does have seizures. This is not making fun of him. He does have them. Okay, he has epilepsy. It's recurrent. Okay. Okay, so seizure disorders. We went through the syncopal stuff. Now let's talk about the seizure stuff with the neuro. Okay, paroxysmal discharge from hyperexcitable group, just like PVCs are an irritable part of the heart. They send off weird signals and you get weird heartbeats. Interferes with the normal functioning of the brain. They can't do things while they're in a seizure-like activity. If they keep having recurrent seizures, then they may have to be having issues with like developmental delays, especially in children, with all the seizure activity. May also occur in normal brain tissue due to other disorders, so acid-base issues, electrolyte disturbances. So seizure doesn't mean, oh, they have a tumor in the brain or something going on. It could be other reasons for it. That's why we do labs to check up on all these other issues or other causes that can have seizure activity. Usually a seizure by itself is self-limiting. It's going to stop on its own and rarely damaging unless they're in a weird spot or when they have a seizure activity, they fall. Do they hit their head when they fall? Stuff like that. So for the most part, they're not going to hurt themselves. Different features clinically depend on the location of the focus, what part of the brain is having these discharges. So remember, we mapped out the brain and the different lobes, and where that seizure activity is happening, the aura that presents beforehand may give you a clue as what part of the brain is being affected by these seizures. The level of their consciousness is going to be altered. Some may have full loss of consciousness, some may have altered levels of consciousness. And when they have a seizure activity itself, they'll have disturbances in motor, sensory, and autonomic functions. It is a common occurrence. Peak incidence is in childhood and then late adulthood after age 60. So seizures are common in kids and elderly. In elderly, new patient with a seizure, what are you worried about? Now you're worried about like tumors and brain damage and stuff like that. That's like I said with the headaches. Any new onset of a headache in an elderly patient, work them up, get a scan of the brain, see what's going on, make sure nothing's getting bigger inside there. 1 in 10 people reaching the age of 80, lifetime probability of having one seizure is about 8 to 10%, 3% chance of epilepsy. Most times they occur outside the medical setting, so you're getting anecdotal evidence from your patient of what happened. Um, Unless they're actually in the hospital seizing, then you'll see what's going on. Otherwise, it's like when you have palpitations, like, oh, I had palpitations 2 days ago, and you go see the cardiologist today. Well, you're going to be in normal rhythm. They're going to inspect you. Everything's going to be normal. But you don't catch anything. That's why you do like 24-hour Holter monitors to try and catch something. With seizures, they do have neural floors in the hospitals, and they usually have one or two. I know in Florida Hospital, or Advent Health now in Orlando, is the main neuro center for Central Florida. They have 2 or 3 rooms which have video cameras and full EEGs, and they are being monitored for seizure activity, mainly in patients who are trying to get off seizure medications. They've been on seizure medications for 20 years, they haven't had a seizure while they're on the medications, and they want to stop the medication. So what they do is they stop the medication, put them in the hospital, and monitor them for a weekend, and see if they have any seizure activity while they're off their medications. And if they don't, then the neurologist will make the call, okay, you can stop your Keppra or whatever, and we'll monitor and see how you're doing. And then so this is the key thing with seizures. You got to figure out, is this a primary CNS problem, something structurally wrong with the brain, causing these discharges to occur, or is there underlying systemic disease? So acid-base disturbances, electrolytes, and so forth. So due to CNS dysfunction, the primary ones are benign febrile convulsions of childhood, so there's febrile seizures. They are benign below 5, so we'll talk about that in a little bit. Epilepsy, trauma, strokes, and mass lesions are all things that can cause seizure activity due to damage to the CNS. Seizures due to systemic disorders, hyperosmolar states. So here's your hyperglycemia, hypernatremia. Hypoglycemia by itself will give you seizure-like activity as well. So again, first thing you always do, once the seizure is done, not while they're seizing, but when the event's over, then you start doing your workup, check glucose, because if it's like in the 20s, that's why they're seizing. Give them, perk them back up and see what's going on. Hypocalcemia can do it, uremia will do it, and here's your hyponatremia as well. So here you got your different spectrums of, obviously, sodium is a big one with different sides. Glucose are big culprits when it comes to seizures. Make sure you check all those. The seizures will usually resolve once you treat the underlying cause. As with most things in medicine, that's why it's so important to stop putting Band-Aids on things and figure out why this patient is here. Why is this patient in the hospital right now in front of me? What are they here for? They're having these symptoms. Okay, what can cause these types of symptoms? And you start doing your differentials and figuring out where this problem is, and you can treat from there. Epilepsy, again, is recurrent seizures. Okay, you can't diagnose just based off of one. People who have a syncopal episode from any cause may demonstrate convulsive movements, but they're not epileptic seizures. That's why it's important to know these underlying things, how do they present, what was going on, because not all people who seize are actually having a seizure itself. Here's the key one: 2 unprovoked seizures greater than 24 hours apart. If it's within 24 hours, your systemic derangements that you're trying to correct don't have enough time yet. So if you have like 2 seizures within 12 hours, that's all due to the same event. But if it's a long period of time in between, then we can say, yeah, this is probably epilepsy because they're having recurrent seizures greater than 24 hours apart. They're considered separate events. Once you have one seizure, though, the odds of you having another one are about 50%. I have a slide coming up that describes that. And once you have a second one, then the odds of having a third one go up even more. So once you have one, your odds of having a second one go up, and then it goes on from there. Epilepsy by itself is only about 0.5 to 1% of the world population will have it. So very, very small number. Okay, idiopathic generalized epilepsy. This is a genetic cause. So obviously ask about family history of seizures. Anyone in the family have seizures? Usually very common between 2 and 14. If they happen before age 2, it's usually due to a developmental defect, birth injury, cerebral palsy, muscular dystrophy. There's something else going on that's usually part of the seizure symptom that they're having. But usually when they're young and they're having recurrent seizures and epilepsy, it's due to something that happened during. They're going to have other developmental problems as well, not just the seizures. And also, there are no nervous system, brain, or spinal cord problems other than the seizures. Everything else is usually intact. When they're not seizing, they're okay. Symptomatic generalized epilepsy, this is widespread brain damage. And then again, injury during birth is usually the most common cause. Okay, so cerebral palsy is usually a problem during development or during birth, traumatic birth, usually shoulder problems and stuff like that. Or inherited brain diseases, those genetic ones that cause the other ways to get these generalized seizures. Again, so in addition to the seizures, they're going to have other neurological problems with it, not just the seizure activity. So recurrent seizures in pediatrics, usually a congenital problem or something due with delivery of the baby. Your metabolic disorders that can cause seizures, here's your ETOH withdrawal. Okay, they'll have those delirium tremens and they get the tremors, and they also may get some seizure activity as well. Uremia, and then here's your hypo or hyperglycemia, both ends of that spectrum. So remember, if they're coming in DKA, they may come in a coma. That is a problem with loss of consciousness. So they're going to come in with altered mental status and everything. How do you know they're not seizing, or is it just due to DKA? Your labs, your history, your physical exam will all give you clues to all that. With symptomatic epilepsy, this is your recurrent seizures. Trauma will be a cause of this. Tumor or that space-occupying lesion. Space-occupying lesion causes that mass effect. And it pushes the brain around, causing issues. And I have a good picture of that in a second. Vascular problems can cause seizures. Your degenerative disorders, Alzheimer's, and then obviously all those infectious diseases can also, again, untreated. Okay, if you have meningitis, hopefully you'll treat that. But obviously HIV/AIDS, untreated, neurosyphilis, untreated, can cause seizures. So the terminology, the seizure itself, convulsions, violent spasms, jerking of the face, extremities, those are the seizures secondary to aberrant electrical activity of the brain. So there has to be some sort of discharge, some electrical activity going on that's causing the issue. Tonic activity, prolonged muscular contraction. So when you see your tonic, clonic, the tonic is this, everything's contracted. That's the tonic phase. Atonic activity, relaxed without normal tone. So when they go to atonic, they just flopped on the bed. Nothing's going on. Clonic activity is the rapid succession of contraction, then relaxation. So a tonic-clonic seizure, they're going to seize, they're going to relax. They're going to seize, they're going to relax. When you guys check for clonus, clonus is that rhythmic beating of the foot due to the Achilles tendon being stretched too much. So that's clonus. So clonic activity, same thing, repetitive movements. That's what clonic activity is. Myoclonic activity, shock-like contractions of muscle groups. Yes?
For the atonic activity, that's without loss of consciousness, right?
They still may have that too. The consciousness we'll get to later on. This is just when they have an atonic seizure, that means they're flopped on the ground, nothing's happened. You ever like sleep and your arm kicks out, or you're just, that's essentially a form of a myoclonic discharge, I guess you could say. That's basically what it is. Jacksonian march are motor seizures that involve one part of the body and then spread to other parts on the same side. So they'll start with their hand will start twitching, and then the elbow will get into the mix, and then the shoulder gets in, so it starts to spread. That's a Jacksonian march. So again, your tonic phase and then the clonic phase, they're just going to go back and forth depending on how long the seizure goes. Ictal is relating to the actual stroke or seizure itself. So the post-ictal phase is following the seizure. So we say post-ictal confusion when regard to a seizure. When people pass out from syncope due to a cardiac cause, they have no post-ictal confusion. That's one of the big clues to say, is this cardiac or neuro? Because when they wake up, they're going to be just fine. And if they wake up, there's no confusion, they didn't lose any bladder or bowel functions, that's probably due to a cardiac cause. And the neuro, they're going to have those issues. Again, epilepsy is recurrent seizures, abnormal paroxysmal discharge. And we've already gone over that. Okay, when we classify seizures, there's two categories, a partial or a generalized. Partial only affect parts of the brain. Generalized is the entire brain. Okay, so partial is going to be on one side. Generalized, the entire brain is now affected. With partial seizures, you can have simple and you can have complex. Both of them can evolve to generalized seizures, and if they do, it means it's spread from one side of the brain, that electrical activity spread to the other side of the brain. Because you do not have total loss of consciousness with a partial seizure. Because again, only one side of the brain is affected. So they're going to have altered levels of consciousness. Generalized seizures, there are 4 of them: an absence or a petit mal seizure, myoclonic, tonic-clonic, and an atonic seizure. So let me see if this video can work on the computer here. Because they don't work on my laptop. Oh, it's working now. Okay. So there's a bunch of
Most chronic back problems are caused by compression from the disc becoming thinner and thinner and thinner as we get older.
med school students again. So there's a major problem right off the bat. They put them on a curb. You want to put them on a flat surface if they're seizing, so they don't hurt themselves. So not on a curb. Okay, so we'll go through a couple more. This is myoclonic. Okay, so again, atonic is loss of motor function, so head drops. That's an atonic seizure, loss of muscle function in the neck. So this is called an automatism, what his hand is doing. He doesn't know that he's doing it. It's just happening automatically. And they're called automatisms. So this is a absence petit mal seizure, which is also known as daydreaming. It usually happens in kids. Usually the teachers see it, and they'll alert their parents. So a lot of stuff in peds is more like what the teachers say, parents. I think this is the last one. I don't know if there's any more. So that's it. Okay. Let me stick back over. Okay, we'll come back to that. Okay. So, seizure disorders. So again, partial, only one side of the brain. If you have a partial seizure with secondary generalization, now we've spread to the other side. So now they have a generalized seizure. This will make them pass out. And then your primary generalized means it spread to both sides. So main characteristic is the level of consciousness in these patients. So a partial seizure will have some preservation of consciousness still. They're not going to be totally passed out or out of it. They'll just be altered. In generalized seizure, they're always going to have loss of consciousness. Okay? And you have to classify the seizure to guide the treatment. Most of them are all going to be the same, Keppra-Dilantin, valproic acid. Some of them, the petit mal ones, have different ones you want to use for those ones. That's really the only difference. Partial seizures, most common type of seizures, can also be very difficult to control. Again, they're not being, you don't see it clinically. It's all anecdotal evidence from whatever happened in the past. In a simple partial seizure, no loss of consciousness. It'd probably be isolated tonic-clonic activity of a limb, like a convulsing jerking. They may have transient altered sensory perceptions, so maybe some tingling while it's going on, some paresthesias. They may have that Jacksonian march. Starts in the hand and then gradually works its way up the arm. With simple partial seizures, some sensory or autonomic symptoms. If they do have these sensory issues, that indicates what part of the brain they're having the seizure activity in. Okay? Light flashes, buzzing, abnormal epigastric things, sweating, flushing, some pupillary dilation, those are other things they may have. Other phenomena, deja vu, what's that? Something that happened before. You see this thing happen before. Jamais vu, what's that? That's when you don't recognize a word that you should know. Like you ever write a word a bunch of times and you look at it wait a minute, am I spelling this right? This doesn't even make any sense. But it's like that. The word is that, and you write it and you're this doesn't look right. That's jamais vu. It's something you should know, you don't recognize. Illusions, hallucinations can also happen. Complex partial seizures are characterized by an aura. Okay, they'll have some sort of abnormal sensation, perception, memory, or emotion before the seizure starts. They'll have impaired loss of consciousness. They'll have some amnesia. They won't forget. They'll forget what happened in that time frame that they were actively seizing. Nausea, vomiting, some sensory issues, some tonic-clonic. Your automatisms may be present, and they only last 30 seconds to 2 minutes. They don't last very, very long. So those are the two for partial. They're simple and complex. Simple. The complex one usually have an aura, and they have some altered levels of consciousness with those patients. Moving on to generalized seizures. This is the first one, is the absence or petit mal seizure. Impairment is brief, less than 20 seconds. And it just looks like they're staring off into space. You say, you call their name, what's going on, and they don't reply, and then I'm oh, what's going on? Those 20 seconds were just gone. So usually seen by the parents, this blank stare, daydreaming, may have some clonic, tonic, or atonic components to it, but usually it's just staring off into daydreaming into space, not doing anything. Starts in childhood and usually stops by age 20. Can progress to other types of seizures as well. So if they have petit mal as a child, they may have the other ones later on as they grow up. Generalized seizures, again, we have our myoclonic. These are just myoclonic jerks, just increase in muscle tone. Your atonic, they're called drop attacks. So in that video, that guy was reading the book and his head just fell. That's an atonic, that's a drop attack. Doesn't last very long, less than 5 seconds. You saw the guy reading the book, his head fell down, he came right back up again. then his head fell down. So that's an atonic seizure. Tonic-clonic is your grand mal seizure. This is the one you see on TV where they're flopping like a fish on the ground. That's not how seizures look, to be honest. It's very different from that. That's one way to tell if your patient's faking it or not. What are they doing during their seizing activity? Because people will fake stuff to get medicine. So you have to make sure they're really having a seizure. That's why you want to do EEGs, because they'll flop on the ground, but the EEG will be normal, that means you're actively making yourself do that. The tonic phase lasts less than a minute. Sudden loss of consciousness. They become rigid, fall to the ground. Be careful for breathing because all the muscles, respiration, they're going to seize up and stop too, so they're not going to breathe for a little bit. And then they go into the clonic phase, which is the jerking that you see with the clonic activity of the seizing. This is where they may get some tongue biting, so you'll see people put a stick in their mouth. I'm not sure that's the best thing to do, but be careful for their tongue. Sphincter relaxation, urinary incontinence. That's why I check for bladder or bowel incontinence after the event's over, because in a grand mal seizure, they're going to lose their sphincter control and they'll lose their bladder or bowel. They may go into a deep sleep, breathing deeply, wake up, may complain of a headache. That post-ictal period for this one could last minutes to hours after a grand mal seizure. Status epilepticus is further convulsings without consciousness between attacks. So they will have a seizure, but they don't regain consciousness, but they're okay, and then they have another seizure. Serial seizures are consciousness, then seizure again. So they have a seizure, they wake up, they're okay, a little bit confused, but then they have another seizure. The effects of the tonic-clonic depend on the length of time they had the seizure. Less than 15 minutes of seizing activity, tachycardia, elevated BP, hyperglycemia, temp goes up. With the seizure activity, some leukocytosis may happen due to the seizure and the inflammation going on. If it happens and the seizure activity lasts longer than an hour, and they're continuously seizing, they're going to have major development problems with the brain. Hypotension with decreased cerebral blood flow, disruption of the blood-brain barrier, leading to our cerebral edema. When you have cerebral edema, what happens to your breathing and the CO2s? Get altered, it makes it worse. It makes the cerebral edema worse, and then it makes it worse, and it makes it worse. So you have to really make sure you treat this. So how do you do it? This is your status epilepticus. It's a medical emergency. We talked about before about an hour. We don't want them seizing an hour. Those are people who are not in a hospital or by themselves, and so forth. Any prolonged activity of seizures greater than 5 minutes, we consider it status epilepticus. Can cause permanent brain damage or death due to the hyperthermia, circulatory collapse, or all that excitable neuron damage. So all that glutamate hyperexcitability we talked about, burning all that area, that's going to happen as well. Mortality rates for a first episode is 20%. So pretty high. So biggest thing, always ABCs. Always check those, make sure the patient's airway, breathing, circulations are okay. You want to break the seizure with lorazepam, Ativan, or diazepam, Valium. Those are good for breaking the seizure. Phenytoin dilantin is prophylaxis for a future seizure. They're not going to break them. You need the benzos to break it. Valium, Ativan. Valium is the better one to use. It's IV. And you give it once every 5 minutes or so, and you want to make sure they break the seizure. Post-ictal phase, symptoms that they're going to have. Headache makes sense. Disorientation, confusion, drowsiness, that's all that post-ictal phase. Nausea, muscle soreness. Why muscle soreness? From all the contractions, it's going to hurt. So your workup for anyone with a seizure, so it doesn't matter what type of seizure they're having, the workup is going to be the same. History and physical is always your most important way to start. Okay, always ask questions. What was happening? What did it, When did it start? What were you doing beforehand? What were you doing afterward? What feel? All that stuff. You got to ask all these questions. Studies, EEG, head CT, head MRI. The gold standard is the video EEG monitoring, like I mentioned before, where you actually watch the patient all day on a video, and if they have activities, then you can roll back the tape and see what was going on with that patient. Treatment is individualized, so not one works for everyone. You have to tell your patient that they're going to be on this medication usually for life. They can't stop the medication or they'll get seizures again. Abrupt withdrawal may precipitate a seizure, which is why the very first question in any patient that comes in with a seizure who is on medications is, did you take your medicine? Because if they stop taking their medicine and they get a seizure, there's your answer as far as why are they getting a seizure. Because if they're on Keppra or Dilantin or any of those things, they shouldn't have seizures. But if they're having breakthrough seizures, first question, are you taking your medications? And if they say yes, you're going to check a level. Most of those anti-seizure medications, you can get levels in the blood to see where they're at, make sure they're right levels. And if they are, then we'll talk about that later on when we get to treatment. Surgical resection of the temporal lobe can also happen as well. So what do they do there? They take off part of the skull and they expose the brain. And they put, I'll blow this one up, use this picture. They put a net, a wire mesh, that looks like that, over the brain, and it's basically an EEG, but it's in a grid pattern on the actual surface of the temporal lobe. And they want to make you have a seizure, so they kind of hopefully try and catch one. So you have to wear this thing or have your brain skull exposed when they cover it. But they want to see where the seizure activity is occurring. And let's say they leave us on your temporal area and they start getting hits here. And that's where the focus starts from. So now they know, okay, let's go into that area and let's ablate that area. Let's knock it out, because that's where the seizures are starting. And they ablate that tissue. You can't conduct electrical activity anymore. And hopefully that ablates the seizures from occurring again. So that's what they do for the surgery part. For that temporal lobe resection, they got to figure out where it's coming from first, and then they go from there. So HPI, again, what was happening beforehand? Or were they sitting? Was it exercise-induced? Think of cardiac. Are episodes followed by periods of confusion? Okay, you're really assessing that post-ictal state. That's what you're trying to find out. How were they afterwards? If they have a post-ictal state, that was a seizure. Okay. Prolonged post-ictal state, obviously if they have status epilepticus, the longer period of seizures, it's going to happen. Post-ictal will be longer as well. So once they've stopped convulsing, everything's stable, the patient's calm and relaxed, now you can start doing some testing on that patient. CBC, glucose, liver, renal functions, CT scan or MRI, rule out hemorrhage or infarct, mass lesions, AV malformations. You're going to check everything. See what's going on. Why is this patient seizing? Okay, EEG, electrical activity of the heart. Like I said in the last, when we talked about diagnostic tests last unit, order it in the ER. Neurology, the EEG tech will come down, they'll do the test, and the neurologist will read it. But at least you're getting it started early. So the neurologist, when they come and see the patient, they're ready to go. Lumbar puncture, if indicated. But again, make sure that you check for structural abnormalities before you do it to make sure you don't cause brain herniation. Emergent non-contrast CT, first-time seizure, emergent indications. New focal deficits with a seizure, get a scan. Persistent altered mental status, with or without intoxication, so ethanol intoxication or whatever drug. Fever, recent trauma, headache that's persistent, any type of cancer. History of anticoagulation, AIDS, first-time seizure over 40. get a scan of the brain and see what's going on. Anyone coming with a seizure is going to get one anyway, but if they have recurrent seizures and now all of a sudden they are getting some changes, just like we talked about with the migraines. If the migraines are the same every single time, okay, I'm okay with that. But if they come in and they say, well, this is a little bit different this time, I'm getting some tingling in my hands, get an image, see what's going on with the brain. So here is a brain mass. And you can see this is the middle. See, everything's being pushed because this huge mass right there. Okay, so that's why you do a CT of the brain, to look for masses and lesions. So urgent scans, first-time seizures, scan performed before disposition, but planned soon thereafter. So these are urgent. They're not like you don't have to get it done right now, but you want to get it done within the next couple of days. They've recovered from the event, but no cause has been identified. So MRI in these cases are usually preferred over CT, looking at those soft tissue changes in the brain. EEG activity, you don't really have to go much into detail with that one as far as knowing what the activity is like. I'm going to show you a video. You're going to see the changes. You're like, okay, I can see that's definitely something going on there. The EEG is not like a EKG where everyone's getting them. They're usually only a specific reason a subset of people will get an EEG. So more time for the neurologist to read all those images. EKG is easier to interpret. Okay, so here's this one. Okay, so this is the video monitoring. Up top is the video of the patient, and on the bottom is the live EEG recording going at the same time. So there's a narrator in this one kind of describing what's happening to the patient as the seizure.
In this example, the patient's seizure begins with a blank stare, which constitutes the complex partial component. Next, we see a brief verbal cry, while the arms and legs stiffen in the tonic phase. The patient's facial expression is a contorted grimace.
Okay, you're okay. You're okay.
The tonic phase lasts approximately 15 seconds, and then transitions to the rapid arm and leg jerking motions of the clonic phase. Clonus continues for 20 seconds, gradually calming as the patient makes gasping automatic movements with his mouth and throat. On the patient's EEG, the epileptiform activity starts in the frontal region. The activity spreads bilaterally, and the EEG is masked by muscle and movement artifact.
Okay. There we go. There we go. Yeah.
They closed them down and then they're now like organized.
Why?
I guess
Okay, you're okay. You're okay. You're okay. You're okay.
So remember, respiration stops during the tonic phase. That's why he's not breathing. It doesn't last very long. Now he's in clonus.
You're fine. Right?
Okay. So that is what a tonic-clonic seizure looks like, not what you see on TV. Okay. So treatment of generalized tonic-clonic or your partial focal seizures. The ones in bold are the major ones that are used. Okay, the other ones are there. We'll talk about them in a little bit, but those are the big ones: Dilantin, valproic acid, Depakote. On your exams, remember all PA exams always have the brand and the generic. So whatever one is fine, you find it easier to remember, that's fine. Keppra is another big one. Topamax. Here's your Neurontin, which is that gabapentin, that neuropathic pain, but again, it's for nerves, and we're trying to stop the nerves from going crazy. So those are the big ones for treatment of seizures. For absent seizures, the big one is this ethosuximide or Zerontin. That's where it changes, because the absence ones, they do different ones. For myoclonic seizures, Depakote and Klonopin are very good. For myoclonic seizures. Epilepsy now, again, recurrent seizures, randomly and unpredictably. So nothing triggers the event from occurring, they just kind of randomly happen. What triggers can include, though, sleep or stress, lack of sleep, the flashing or strobe lights. That's why a lot of like movies or games that have the warning sign, like if you suffer from high flashes, blah, 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 don't watch it because that can do it as well. Here's your low blood sugar again. Okay, always watch out for sugars. Alcohol, medications, hormones, and illness. Individuals have different seizure thresholds. So what for one person, this event may trigger a seizure. Someone else may not have that same reaction to it. And again, this is the big one right here. For them people taking medications to control the seizures, the big reason to have one is to not take their medications. Some complications of epilepsy. Don't work around moving machinery or at heights. Okay, makes sense. You want to have them have a seizure on the job and then fall. Driving is a big one. Really, anyone that has a syncopal event, whether it's seizure or even cardiogenic, if they're not treated and they're really no underlying reason, unexplained syncope, they got to stop driving for 6 months. And you have to submit it to the DMV. Because if they get into a car accident and you didn't submit the paperwork and you just said don't drive, they still continue to drive. I mean, I'm not saying you're going to get in trouble for that, but CYA, and make sure you follow the procedures and make sure that DMV knows, and make it very important that you cannot drive because you don't know when these seizures are going to occur. Side effects of drug treatment must be monitored as well, because all anticonvulsants can lead to hematologic or hepatic toxicity. So you have to know your baseline CBC and liver function before starting these medications. So do it at 2 weeks once you start, check in 2 weeks, then a month later, 3 months later, 6 months later, and once they're stable, there's no changes in LFTs, they're not anemic, then you can do it every 6 months after that. There are a lot of drug interactions when it comes to all these neuromeds. So we get to neuro with Dr. Wood. He'll go through all those a lot with you then. Recurrent seizures while on drug therapy. Again, missing a dose is the most common one. So determine serum level of the drug. So you can get a valproic acid level. If they're on valproic acid, see what those levels are. MRI to rule out any structural lesion, because again, they're having seizures while on a medication. And if they're taking their medications and they still had a seizure, you want to make sure they're not having any mass, brain mass or something causing an issue. Lifestyle factors, you can also change to a second drug. Go to neurology if they're not controlled within 3 months. Usually everyone's going to see a neurologist anyway if they have a seizure. And then your refractory seizures, meaning they're not responding to your medications. You put them on Keppra, it didn't work. You put them on Dilantin, didn't work. You put them on topiramate, nothing's working. You put them on multiple drug therapy, they're still having seizures. Then they're recurrent, then you can start worrying about that surgical excision we talked about, or even vagus nerve stimulation to help calm the brain down. Remember, vagus nerve is parasympathetic. So if you stimulate that vagus nerve, it's going to hopefully stimulate the brain to calm down. If the first drug gives you partial control, add a second one. And these are the good ones as secondary drugs to add on. Here's your Neurontin, Topamax, Trileptal, and Zonegran. The Neurontin and Topamax are the big ones. Trileptal is another big one as a secondary drug to add on to get better control. Prognosis of seizures. This is what I was talking about before. Unprovoked seizure, after 50% of patients will have a recurrence. If you have that second seizure occurs, then your recurrence rate is up to 75% of having that third seizure. That's really it on seizures. You just put them on those meds and then you titrate up. But if you maxed out, you had a second one. Narcolepsy, irresistible sleep attacks, episodic muscular atonia, okay, so weakness when awake. It's a CNS disorder with abnormal REM brain waves while awake. So they go like into a REM sleep with narcolepsy. They just go right into REM and then wake up again. That's what narcolepsy is. Prevalence in the United States is only 0.007%. Diagnosis is with a sleep study and neurology consult. Sleep studies, basically you go into a facility and they hook you up to like the breathing machine, heart rate monitor, pulse ox. They watch you and you go to sleep at night and they monitor you and see how many sleep apnea events you have, and then obviously look at your brain waves to see what's going on with those, and neurology as well. Treatment for narcolepsy, sleep hygiene, napping is very important. Avoid drugs that worsen daytime sleepiness. That's going to make you go to sleep easier. Psychosocial support. The last thing, they do have some CNS stimulants, so modafinil is a good one to keep people awake more. Ritalin, amphetamines, basically those speeds, they will also keep them awake. Coma. Again, this whole lecture about loss of levels of consciousness or disorders of consciousness. Coma is really considered a transitional state. Either they're going to become a persistent vegetative state, either they recover, or brain death. So they don't stay in a coma. Either they'll be in a coma for a little bit, but then after a certain amount of time, you're like, okay, are they going to recover, or are they going to be a persistent vegetative state, or brain death? Prognosis depends on what put them in a coma in the first place. Why are they in a coma? Is it medically induced coma? Okay, that's one thing. Do they overdose on something and they're in a coma? Usually if they overdose and they're in a coma, once the drug gets out of the system, they'll wake up and they'll be okay. Do they have a mass bleed in the brain? Okay, and that put them in a coma. They're going to either go to brain death or a persistent vegetative state from there. So that's why it's a transitional state. Brain death. Irreversible loss of function of the brain, including the brainstem. Okay, why is that important that we include the brainstem? Because vital signs, your breathing, heart rate is all in the brainstem. When that gets affected, you can't support your vitals anymore, and you need support. Brain death from primary neurologic disease. Severe head injury, here's your subarachnoid hemorrhage, that brain bleeds, again, they don't recover from those usually. Other irreversible loss of brain function may follow hypoxic ischemic brain insults. Also hepatic failure. Okay, we can't clear all the toxins, they become too high and they affect the brain. Mainly ammonia that causes it. So the cause of brain death must be demonstratively irreversible. Okay, because if it's reversible, then then they can become better. So it's not really brain death. Either they had an acute CNS event compatible with a diagnosis of brain death. Exclusion of complicating medical conditions, so they have to have all normal blood levels. No drug intoxication or poison. They have to be free of all the toxins, the drug out of their system before you can say that they're brain dead. This last one is important too. They have to be warm. Okay, you hear stories about people that fall into these frozen lakes. Their body goes like a hibernation. You pull them out of the water, their body is like 40 degrees. They're not breathing, nothing's going on. They warm up and they're okay. So you have to warm and dead before you can declare them as dead. They have to warm up. Documentation of the medical record for brain death. Irreversible condition. We have to prove that whatever happened to this patient cannot be reversed. Massive brain bleed, subarachnoid hemorrhage. That's not going to be reversed. Absence of brainstem reflexes. What are the brainstem reflexes that we learned about? Babinski. What else? Abdominal reflex. What else we learned about? You put the water in the ear, the caloric testing. That is also a brain reflex. You do some corneal stuff as well, but the anal wink is another one. Cremasteric reflex in men is another one. But again, those are the brainstem reflexes. They're not going to work because the brain is not working. Absence of motor response to pain. So again, noxious stimuli, a pen on the thumbnail, knuckles on the sternum. Those are noxious stimuli. Normal, you will wake up from that pain. They will not register the pain at all. So if there's no guarding, there's no pulling back, there's nothing response to that pain. Absence of respiration with a PCO2 greater than 60. What is the normal CO2 in the blood? Around 40. And remember, CO2 is the main drive for respiration, not oxygen. It's CO2. And whenever having a high CO2, what should they be doing when a high CO2 level is in the blood? Hyperventilating. And there's no respiratory response to that high CO2. That means the brainstem, all those receptors aren't working. They're not registering it, no response. You have confirmatory testing on EEG, angiography. Again, EEG will show no spikes, nothing going on in the brain, therefore no electrical activity. The last part is the important part. Repeated neural exams, 6 hours apart. And if they're the same 6 hours apart, again, indicative of brain death. Okay, so we are done with disorders of consciousness. Come back at 11:10, and we'll do the last lecture, and we'll be done.